Good morning and welcome to the webinar. We are happy that you're here. We thank you for joining us today. Our topic is neuropsychiatric symptoms in Alzheimer's disease and other dementias. These complimentary webinars are brought to you through a collaboration of sponsorship with O'Connor Mortuary, Caring Companions at Home, and Alzheimer's Orange County. And my name is Kim Bailey, and I'm with Alzheimer's Orange County, and I will be your host today. Our sponsors are providing these webinars to you as a service to the community on topics that are beneficial for anyone who cares for and works with older adults. We hope you find today's presentation informative and useful. Today, our presenter is going to be Dr. David Sulzer. And before I introduce him to you, I want to review what you need to know if you're interested in earning continuing education credit for today's webinar. Next slide, please. CE credit is available for RCFE administrators, licensed RNs and LVNs, and for LMFT, LCSW, LEP, and LPCC professionals through CAMP and the BBS. You must be online for the full 60 minutes. You must have access to both audio and visual components on your computer. If you want CE credit, do not share your link to join with others. This is your unique record of attendance. If you share your link or use another attendee's link, you will not receive CE credit. Please answer the poll questions immediately. This is a proof of your actual active attendance. If you have problems accessing or answering the poll questions, please type into the chat box to let us know that you're having trouble, and you can always type your response directly into the chat box if you're not able to submit it electronically. We must know that you're actively attending. If we don't get any response from you, we're not going to be able to issue your CE credit. Please complete the survey immediately as you exit the webinar. You will only receive a survey link by email if you do not complete this survey when we close out of the webinar. Let's see, the email with the link, survey link is sent out 24 hours after the end of the webinar, and this link is unique to you and your attendance. So again, please don't share that with others. A certificate of completion will be issued to you by email within 10 days, as long as all the other CE requirements are also met. Some basics for everyone: your mic and video are automatically disabled and will remain so throughout the presentation. However, that doesn't mean that you're not able to ask questions. We will be doing a Q&A at the end of this session, so you can type your questions into the chat box for Dr. Sulzer. If the Q&A session runs long, you're welcome to stay for that, but if you're requesting CE credit, you're only required to stay for the 60 minutes. We won't be responding to raised hands. Let's see. And also remember to complete the survey as you exit the webinar. With all that said, I want to introduce our wonderful speaker today, and that is Dr. David Sulzer. Next slide, please. Dr. Sulzer, can you go to the next slide? There we go. I want to brag about you a little bit. Okay, Dr. David Sulzer is professor in the Department of Psychiatry and Human Behavior at UC Irvine. He leads the clinical core of the UCI Alzheimer's Disease Research Center, contributes to the overall clinical research mission of the UCI Institute for Memory Impairments and Neurological Disorders, known as UCI Mind, and he directs the clinical trials program within UCI Mind. He received his medical degree at the University of North Carolina in Chapel Hill. He completed his psychiatry residency at the UCLA Neuropsychiatric Institute and Hospital, and also completed his neurobehavior fellowship at UCLA. Dr. Sulzer is principal investigation for many ongoing clinical research projects with interests in cognitive aging, Alzheimer's disease, and other neuropsychiatric syndromes in older adults. He has designed and completed many clinical trials to develop optimal treatments or preventative interventions for Alzheimer's disease and other neurocognitive syndromes, including trials that target accompanying symptoms of psychosis, mood alterations, or behavioral disturbances. Dr. Sulzer has published widely in many top-tier medical journals. He's received several awards for his research work and is recognized nationally for his academic activities related to geriatric psychiatry and Alzheimer's disease. He is a distinguished fellow of the American Psychiatric Association. And with that, I will turn it over to you, Dr. Sulzer. We are very excited to hear your presentation, and we thank you for joining us.
Great. Thanks so much, Kim. Appreciate the very kind and perhaps oversized introduction, but thank you very much. Good morning, everybody. It's nice to join you this morning, and I'm really pleased to be able to be part of this educational seminar series supported by Alzheimer's Orange County. It's a great opportunity for all of us to learn from each other. Hopefully, some of you may have been able to attend the UCI Mind Alzheimer's Disease Research Conference. It was just last Friday, so it's a great few days in looking at educational opportunities in Alzheimer's disease. What I'm going to be doing today is spending a little bit of time talking about psychiatric symptoms in Alzheimer's disease and other dementias. As most of you are aware, we typically think of Alzheimer's disease as primarily a cognitive disorder, cognition being memory, thinking, perception, problem solving. But we're also learning, and most of you are aware, that psychiatric symptoms such as depression, anxiety, irritability, apathy are also truly fundamental parts of the Alzheimer's disease clinical syndrome. And so that's what we'll be focusing on today. Just by means of introduction and to lay some context for things, you'll see three gentlemen here on this slide, Sigmund Freud on the left, Emil Kraepelin in the middle, and Alois Alzheimer on the far right. These three clinician scientists were involved in looking at a variety of neuropsychiatric syndromes now around the turn of the previous century, around 1900. Sigmund Freud on the left was a neurologist actually by training, went to visit Charcot in Paris, which is the bottom left picture there, where he learned about hypnosis and the impact of hypnosis on treating psychiatric syndromes. He was fascinated by this, went back to Vienna, and really pivoted his career from that of neurology, where he was looking at aphasias and neuroanatomy, to develop what later became psychoanalysis, a very different line of thinking from traditional neurology. In contrast, on the far right, Dr. Alzheimer was a psychiatrist who worked in the equivalent of the state hospital system in Germany around the turn of the previous century. With the advantage of using new stains that were available to look at brain tissue, he recognized a patient he cared for who had pretty severe behavioral problems that are relatively young for an older person age, and recognized the neuritic plaques and neurofibrillary tangles that are shown in the bottom right there that are part of the syndrome of Alzheimer's disease. So in his case, a psychiatrist providing key insights into what we consider largely now a, quote, neurologic illness. And then Emil Kraepelin in the middle, who actually is a contemporary and colleague of Professor Alzheimer, who looks disturbingly like Sigmund Freud. One could imagine that they're actually the same person, but they're not. And but although born within the same year, and he, along with Alzheimer, was really developing these ideas about what are the symptoms that occur in these different disorders, a pioneer in what became He described dementia precox, but is currently referred to as schizophrenia. So this interesting interplay over a fairly short period of time in a very close neighborhood of Europe around 1900, and showing the interplay and the interface between psychiatric syndromes and neurologic syndromes. And that sets the stage for the current time, where we're really thinking of these symptoms as a cluster that emerges from brain pathology or brain proteinopathies, but are reflecting a clinical syndrome that has both cognitive and psychiatric symptoms. Most of you are familiar with Alzheimer's disease, and it's the concern currently about its increasing prevalence in the United States and around the world. That in the bottom left there, it shows the difference in age distribution between 1960. I think I can get a pointer going here, maybe not. Not sure if you can see my pointer on screen, but the 1960 and 2060 for this century, distribution of ages between being born at 0 and then top line is 85 and above. And that you can see over this 100 years, there's a dramatic increase in the upper levels of the population. And we now know that in the United States, the over 85 age group is the fastest growing part of the US population. When you map that onto the fact that somewhere between 30 and 40% of adults over the age of 85 have Alzheimer's disease, creating what has become and will be increasingly over time a major healthcare problem and great challenges for the healthcare system, for caregivers, for families, for healthcare financing via Medicare and Medicaid programs. So a huge issue. Of great note, there's now, as you're probably aware, 2 new medicines that have been approved for treating mild cognitive impairment or mild Alzheimer's disease dementia. So these are treatments that are monoclonal antibodies that actually address the abnormal accumulation of amyloid protein in the brain. That's what drives the development of Alzheimer's disease. The top 2 curves there show the ability of these medicines to pull amyloid out of the brain, lecanemab on the left, donanemab on the right. And you can see in that top row of charts that compared to placebo, the drugs pull amyloid out of the brain quite substantially. So that over a period of about a year, year and a half, the majority of people essentially have no more amyloid in their brain than do those who don't have Alzheimer's disease. This is mapped onto clinical improvement shown in the bottom row of charts that show clinically over the 18 months of these trials, while the placebo group is declining, the active treatment groups unfortunately continue to decline, but at a more shallow slope compared to the placebo treatment groups. And the current focus in the field is to try and improve the shape of that curve so that the active treatments that are available can slow the decline even further or potentially arrest the development of clinical symptoms. And we, along with other sites nationally and internationally, are doing a trial currently using lecanemab to treat people, older adults who have amyloid in their brain but have no memory difficulties yet at all. So to be able to hopefully prevent the development of memory impairment due to this abnormal protein. So it's an exciting time. This is mostly focused on cognition, but we're looking at similar opportunities for psychiatric symptoms as well. Of note, both of these sets of trials for these 2 drugs did not include measures of psychiatric symptoms, so we don't know what the benefit may be on those symptoms, but we'll learn more over time. This then shows an overview of the psychiatric symptoms that occur. It's probably a little hard to see on your screen, but for the different groups of people, cognitively normal, those at risk for Alzheimer's disease, those with mild cognitive impairment, and those with clinical Alzheimer's disease dementia from left to right, showing 12 bars that include each of the categories of psychiatric symptoms that can occur in Alzheimer's disease: delusions, hallucinations, agitation, depression, anxiety, euphoria, apathy, disinhibition, irritability, motor changes, and sleep and appetite changes. And you can see that the point of this is not to look at each one of these bars. That would be complex and overwhelming, but to be able to just look at, you can see the size of the bars go up as groups shift between normal to Alzheimer's disease dementia. And when you get to the AD dementia group on the far right, prevalence of each of these symptoms is getting up to be 30, 40%, highlighting the common frequency of these symptoms in Alzheimer's dementia, the fact that some of these symptoms are emerging earlier on, even when people are at risk prior to having true dementia with a lot of memory difficulties. And we know that these symptoms are a major part of the illness. They promote patient distress, compromise safety. They drive decisions to institutionalize people with dementia because of their psychiatric symptoms. They contribute prominently to caregiver burden, distress, and lower life quality. And they also increase healthcare costs and utilization by about 50% compared to those who don't have psychiatric symptoms, but do have Alzheimer's disease. Oops. Later on in the talk, depending on time, I'll mention a few words about mild behavioral impairment. These are symptoms, similar symptoms, but occur much earlier in the development of Alzheimer's disease dementia. We know that these symptoms among older adults and those at risk promote more rapid progression to mild cognitive impairment and Alzheimer's disease dementia. So this is an important new area we're looking at, highlighting the contribution that psychiatric symptoms may actually play in the evolution of Alzheimer's disease dementia, or may be an early expression of the degenerative brain process. But we'll talk more about that in a few minutes. So where do these symptoms come from? What causes them? One way of looking at this, we've looked at this in our group and others nationally and internationally, is to recognize that when you look at regional brain function among people with Alzheimer's disease, you see common problems that occur in this group, but each person with Alzheimer's disease has a little bit of a different pattern of difficulties in their cortical function. And that if you look at those differences and map them onto psychiatric symptoms like apathy, delusions, hostile agitation, that these symptoms actually map on to particular patterns of brain dysfunction. The colored things there in the yellows and reds highlight where in the brain are cortical metabolic activity reduced or more impaired in those who have each of those symptoms compared to those who don't, all of them having Alzheimer's disease. So there's sort of a signature, if you will, for each of these psychiatric symptoms based on regional brain function, highlighting that these symptoms are really an expression of fundamental brain processes, and kind of get away from an idea that the psychiatric symptoms in Alzheimer's disease are caused by really nothing more than a globally broken brain, if you will, that really promotes the expression of this variety of symptoms. There's much greater specificity to it than that. So also in thinking about where symptoms come from, it's important, we've talked about neurobiology there in the top left, but then there are also other contributions, social, environmental, and medical, highlighted there on the right, upper right, that those non-biological factors include one's psychological makeup, social and cultural issues, caregiver interactions, environmental changes and stresses, and medical conditions that include things like pain that can actually contribute prominently to the expression of these symptoms shown below as agitation, psychosis, anxiety, etc. So this provides kind of a framework for how we think about these symptoms, and also highlights kind of the ways we're thinking about managing these, addressing both neurobiological as well as social, environmental, and medical contributors, and encourage you to think as you're thinking about these symptoms and work with clients who have such symptoms to embrace such a framework, because it provides a broader range, if you will, and an opportunity to really apply specific treatment strategies to people who have particular contributions to their own pattern of symptoms that we're seeing. So we'll spend a few minutes now talking about agitated behaviors. These are the behaviors that are often most troubling to people. They also can be come with safety concerns, and again, have a big impact on decisions to institutionalize or need additional higher levels of care for folks. That unfortunately, the term agitation is used quite broadly, and that it really refers to a collection of behaviors that that are each described individually by the way you see agitation and what your framework is, which makes it hard to communicate across providers and settings, et cetera. That the field has tried to focus in on recognizing that these are variable behaviors, but include, three main components. One is physical aggression, another is verbal aggression, and the third is excessive motor activity. Physical aggression being, unfortunately, hitting, striking out, being physically resistive. Verbal aggression, shouting, screaming, targeted profanity. And motor activity, some people with dementia just need to be moving all the time. And it's just motorically a problem. It sets them up for falls and causing other problems in their local setting as well. That these symptoms are common, occurring in as many as half or 2/3 of people with Alzheimer's disease, agitation in general, but physical aggression, that component, being a little bit less common, but still 10 to 25%, which is not uncommon. As I mentioned, these symptoms are associated with a variety of unfortunate consequences, but also that includes things like rapid cognitive decline, that those people with Alzheimer's disease who have agitated behaviors tend to progress more rapidly with regard to memory and thinking over time. Also, more frequent falls, and interestingly, increased mortality, that the survival time is shorter for people who have Alzheimer's disease with agitation compared to those who don't. Do you want to do the poll question?
Absolutely. Okay, everyone. Quickly answer our first poll question. Excessive motor activity is a type of agitated behavior. Is that true or false? I see everyone weighing in very quickly. So I think we can go ahead and release the results. And it looks like almost everyone got that. That's great. So let's go back to you now, Dr. Salzer. Thank you.
Great, thanks. There. Thanks, Kim. Way to go. So now we come to addressing agitated behaviors. There's this panel shows a variety of kind of conceptual things that I think is probably one of the most important. This comes from the Alzheimer's Association monograph recently that you can check out as well. But I think the first thing that we think about is, what are the specific behaviors? Because agitation can be considered quite broadly, that it's important when you're working with someone who may have these behaviors to think about exactly what's happening, what's going on. Things like, what's the immediate cause? What's happening in the 5 or 10 minutes before someone has an episode of agitated behavior? We're also thinking about medical causes, things like pain, delirium, medication, sensory deficits can all contribute. And those are things that we really need to address right up front, because trying to manage the agitation without addressing these things is just not going to work very well. Pain is often underappreciated in people with Alzheimer's disease and other dementias. There's been some work done looking at the benefits of Tylenol for treating agitation, highlighting that it can be somewhat effective for many people, partly because there's underlying pain that's not been previously recognized. So think about the medical things, particularly pain. Other principles are things like don't get upset. Agitated behaviors are upsetting, but to the extent the environment and caregivers and support team and staff can kind of keep a handle on their own irritability and distress, which is hard to do at times because these are distressing behaviors, that has an impact typically on how the behaviors unfold and resolve. That people with even advanced Alzheimer's disease are very sensitive to the experience in the room, the affect in the room, the mood in the room, so that when someone with Alzheimer's disease sees their spouse caregiver, for example, who's upset and distressed, that's distressing to them and can actually exacerbate the agitated behavior. So to the extent possible, to kind of relax and resist the temptation to get loud or particularly upset. Other important things here, a great principle is shifting the focus to another activity, that people with Alzheimer's disease sometimes kind of get stuck on a thing they're working on or a particular thought or feeling, and just breaking that cycle, taking a walk or shifting, moving on to just another activity in the home or setting can be very, very helpful. We're always going to want to ensure safety and in particular, get the support that you need as a caregiver, that whether you're a professional caregiver or a home caregiver, that caring for someone with Alzheimer's disease or other dementias is not simple, and that we all need the support of family and friends, but particular in when you're managing someone who may have these challenging behaviors, and it's a 24/7 job, obviously. So be sure to get the support you need. Those are kind of some general principles. When we kind of think about then specific interventions, and some of these will overlap with the principles, we're thinking of three domains. One is education, the second is problem solving, and the third, as I've alluded to already, is support. That in those domains, focusing on the caregiver, problem solving behaviors, what are the triggers, what are the routines that can be helpful to be reassuring to people with dementia, because their distress and confusion may contribute to their distress leading to agitated behavior because they don't understand. So to be thoughtful and reassuring can be helpful. Distraction I've mentioned, as well as managing the affect. That for the caregiver, we encourage folks to have the support they need, as I've mentioned, and to take time for themselves to get the help you need to be able to be the best caregiver that you can. There are a number of other strategies there, respite groups, support groups that can help promote this opportunity. Then to focus on the person with dementia, things like repetition, redirection, and reassurance can be helpful. That, people, the redirection is just to kind of break that cycle where someone may be stuck on something that's distressing, and to provide the reassurance, to improve the communication as best as possible, and to kind of divert the focus to more pleasant activities and social engagement. Those kinds of things, both acutely as well as over time, tend to reduce the likelihood of agitated episodes emerging. And then finally, the environment, that probably the best example is having the right level of stimulation. This is a little bit more for care homes, for example, where the amount of noise can be either way too high or way too low, that we recognize can be agitationogenic for people with moderate to advanced dementia, just because it's either overstimulating or this understimulated and bored that can lead to behavioral issues. Do you want to do the second question, Kim?
Okay, let's do it. Exercise or engagement in pleasant social activities can improve neuropsychiatric symptoms. Audience, is that true or false? Once again, exercise or engagement in pleasant social activities can improve neuropsychiatric symptoms. All right. I think just about everybody has weighed in. Let's go ahead and share those results. And it looks like everybody did fantastic again. So back to you, Dr. Salzer.
Thanks, Kim. And once again, way to go, everybody. We'll shift a little bit now, I believe, yes, to medications. We've covered the behavioral or psychosocial interventions for agitation. And I'll now spend a little bit of time, a few words on medications for agitated behavior. That cholinesterase inhibitors, medicines such as donepezil, rivastigmine, galantamine, that are used to treat Alzheimer's disease per se, the cognitive disorder, and have modest benefit. There's some evidence that people who take cholinesterase inhibitors or memantine, another class of medicines for Alzheimer's disease, may have less likelihood of emerging behavioral symptoms over time. That's looking at people who actually don't have agitated behavior, for example, when they start taking the drug. But that when you look at the emergence, there's a little bit less over time. However, unfortunately, if you look at people who have agitated behaviors who aren't on a cholinesterase inhibitor and treat them, there's not been, in a couple of studies, there hasn't been significant benefit seen, in this case with donepezil versus placebo, for treating agitation in Alzheimer's disease. In clinical practice, if somebody isn't taking one of the medicines for Alzheimer's disease, we'll often, and we're considering starting it anyway, just to help them with their cognitive symptoms, we'll also we'll consider the behavioral symptoms another reason to consider treatment, recognizing that some people will gain some benefit, although in large groups, not a significant amount. But we think about that and we're making decisions about treatment options. In contrast, the atypical antipsychotics, such as aripiprazole or Abilify, olanzapine, Zyprexa, quetiapine, Seroquel, or risperidone, Risperdal, are atypical antipsychotics that have been kind of the mainstay of treatment for agitated behaviors over the past 20 years. There's a long story to this, and in the interest of time, I'll highlight just a couple of points. One is that the magnitude of their benefit for agitated behavior has historically probably been overrated. And this slide is a confusing set of data, but it highlights nicely all the trials, most of the trials that have been done using these medications for treating agitation in Alzheimer's disease, and that in the trial, if the drug was better than placebo, the points, circles, and diamonds are to the right of that blue line in the middle. On the other hand, if placebo is better, which wouldn't be what we would want, those circles, diamonds, and dots are to the left. And you can see most of the trials show diamonds and circles to the right of the line. However, you can see that some studies really don't show a whole lot of benefit of these medicines, and the distance of the benefit from the line for these is not particularly high. And that we think of these things in terms such as effect size. The effect size for treatment of agitation with these compounds overall is calculated as 0.2. And for context, that's about the magnitude of benefit that we see with cholinesterase inhibitors such as donepezil for the memory challenges of Alzheimer's disease. So the medicines are on average modestly beneficial, but the magnitude is not great on average. Now, of course, in clinical practice, we're hoping that an individual will respond better than someone who may not, obviously, but we underappreciate, I think, both the placebo effect and the optimistic sense that these medicines are being more effective than they are. That doesn't mean we shouldn't prescribe them, and they are prescribed. There's been concerns about that. Fortunately, the quantity of medicines being prescribed in these conditions has declined, of atypical antipsychotics has declined over time, which is a good thing. And again, these are the class of medicines that has the best track record for being effective for treating agitation, although the magnitude, again, is modest. Some work we've done, and one of the things, since agitation is a constellation of symptoms, we've asked, are there specific symptoms that respond better? And parsing a data set from the Katie study a number of years ago identified this syndrome of symptoms that included hostility, suspiciousness, uncooperativeness, anger, oppositional behaviors that were probably more responsive to atypical antipsychotics in this trial than were some of the other symptoms. For example, anxiety or kind of the motor symptoms that didn't typically respond robustly, whereas these more hostile suspiciousness symptoms improved by about 30%, which was the largest improvement across behavioral measures. So I think we're getting better at targeting how best to use these medicines. That targeting is important because this class of medicines has significant adverse effects, and many of you are familiar with this. This has received a lot of attention in the press, as it should. That in particular, the extrapyramidal effects, which are things like rigidity and leading to things like falls. There can be cognitive decline associated with treatment with these medicines. It isn't dramatic, but in a group of people who already have cognitive difficulties, we don't want to see further memory impairment based on our treatments. There's also a signal for cerebrovascular events such as stroke and mortality or death among people taking these medicines. And that too has been controversial but important. And the taking these medicines increases your risk of mortality over a few month period of time by about 50 to 70%. So it's still low numbers, but it's not a trivial effect in this population. So we want to be very cautious and careful in how medicines and have good reasons. You may be aware that all the medicines we've talked about thus far are not FDA approved for the treatment of agitation or psychosis in people with Alzheimer's disease. They're used off-label is the term that we use. And just recently, the FDA approved another atypical antipsychotic called brexpiprazole for the treatment of agitation in people with Alzheimer's disease. The curve there, the chart shows the change over time among people with agitation who were treated with placebo or an inactive treatment versus brexpiprazole at either 2 milligrams or 3 milligrams, showing that brexpiprazole, the agitation score declined more substantially over time, particularly after 4 weeks or so. That the FDA felt that this was sufficiently compelling to approve the drug for this indication. It turns out when you look at the magnitude of benefit, it too is not a dramatic benefit. It's statistically significant and clinically meaningful, certainly for some people taking the medicine, but the magnitude of benefit is not overwhelming. So we're still kind of tinkering with understanding who best to apply specific treatments to. And we're also mindful of side effects that it appeared that there were fewer extrapyramidal symptoms with brexpiprazole, although that wasn't entirely clear, that there's some sedation. There also appeared to be an impact on cognition because the sample was a little bit smaller than the global analyses looking at all other antipsychotics. It's a little hard to compare. There was a signal for increased mortality in the treatment on the group treated with brexpiprazole compared to placebo, suggesting that many of the adverse effects are similar to the other atypical antipsychotics, although some may be slightly less of a problem with brexpiprazole. So we're going to hear more about that. I mean, because brexpiprazole is on label and branded, it's considerably more expensive than some of the other medicines I described. So we're still learning in what group, how best to apply which medicine for which person and which behaviors. One of the things that we're all looking forward to in the future is alternative treatments for agitation using compounds other than atypical antipsychotics to improve the magnitude of benefit on average and reduce the side effects experienced by patients. One of those is a serotonin reuptake inhibitor, an SSRI called citalopram, typically used to treat depression. And there's been some evidence and good evidence from a trial from a number of years ago using citalopram for treating agitation in Alzheimer's disease, showing improvement in the citalopram group of about 40% of people who had moderate or marked improvement compared to a smaller 26% among those who were treated with placebo. That, unfortunately, there were side effects, as there are with all medicines, but with citalopram, that included some heart conduction concerns that weren't particularly dire. On the other hand, were not advantageous in a group of older adults, for sure. And the FDA, the treatment target here was 30 milligrams a day, and most feel that older adults probably shouldn't be treated at a dose higher than 20 milligrams a day. So this study was kind of then redone using S-citalopram or Lexapro, which is an antidepressant that's chemically similar to citalopram, but may have more central nervous system effects and less cardiac effects. And in fact, that study has just recently been completed, and the preliminary results were presented just a month ago at an international meeting, unfortunately suggesting that the magnitude of benefit with escitalopram was not a whole lot more than placebo. So it's still controversial that there are still some side effects. So it's a work in progress, but we're looking to see for opportunities for medicines like citalopram to play a role. And many clinicians currently prescribe this, so you may see it in your work and travels. And then to kind of wrap up for agitation, there are a lot of compounds that are being looked at. If you look at that wheel on the right there, includes the 127 medicines that are currently in trials with humans to identify opportunities to treat Alzheimer's disease, not animal models, but in phase 1, phase 2, or phase 3 human trials. That blue pie shape down at the kind of 7, 8 o'clock period of the clock are the blue ones are the ones that are treating neuropsychiatric symptoms and include about 25% of all the meds in development for Alzheimer's disease. So the future is bright. The goal, again, is to identify compounds that can have an impact on agitated behaviors, be targeted towards specific things involved in agitation, and also have fewer side effects than what we're currently using. There's a list there on the left-hand side that includes many that are in development that you'll be hearing more about as time goes on. So that's agitation. To shift then towards a different neuropsychiatric symptom, that of psychosis. Psychosis are delusions or false beliefs or hallucinations, either visual or auditory, most commonly, among people with Alzheimer's disease or other dementias that also have a big impact on well-being, on distress, on institutionalization, for example, and that Lewy body dementia, another dementia syndrome, and Parkinson's disease, either with or without dementia, are highly susceptible to visual hallucinations. It's a fundamental part of the proteinopathy that they have that's driving their cognitive disorder, but also driving the visual hallucinations. That they're fairly common, like in Parkinson's disease, 30 to 40%. It also is visual hallucinations are partly related to dopamine replacement therapy, things like Sinemet or L-Dopa. Those medicines are very, very important for people with Parkinson's disease to help improve their motor symptoms, their tremor, and their rigidity and bradykinesia. On the other hand, those same medicines exacerbate visual hallucinations. So kind of caught between a rock and a hard place on that. Most people will reduce the dopamine replacement medicines to the extent they can, but then once they're at the point where motor symptoms will emerge if they drop lower, we'll consider treating the actual visual hallucinations. We try and just reassure folks, and it turns out that in contrast to people with advanced Alzheimer's disease, people with Parkinson's disease are aware that these visual experiences are not normal. So they tend to be less distressing, although certainly can be annoying. And we kind of work with reassurance, ask patients what their level of comfort is. And then if medications are necessary, we'll consider an atypical antipsychotic, the ones listed here. They're most commonly prescribed. Quetiapine is the most common. Pimavanserin is a new medicine that, again, has a different mechanism of action that's promising and has been FDA approved for psychosis in Parkinson's disease. So that's a new opportunity in the medication realm. Do you want to do the final poll question, Kim?
All right. Visual hallucinations are not common in Parkinson's disease. Again, visual hallucinations are not common in Parkinson's disease. Let's go ahead and have you quickly weigh in with your response. And once again, if you have difficulty, you can put your answer in the chat. Okay, so let's go ahead and release the results. And it looks like we had a little bit of a mixed bag here. on the answering.
Yeah, and to clarify, I mean, visual hallucinations are common in Parkinson's disease. I think what we may be seeing here is the consequences of the semantics of the question that make it a little bit more challenging for some.
Thank you, Dr. Sulzer.
So then getting close to wrapping up, a few words about depression and anxiety in Alzheimer's disease. Both, interestingly, and we'll come to this in a minute, depression is a risk factor for dementia. So these syndromes kind of overlap. That depression is particularly common in vascular dementia, those who have memory and thinking problems related to stroke or other cerebrovascular events, rather than Alzheimer's disease, although it can occur in Alzheimer's disease as well. That when we think about how best to approach it, physicians sometimes prescribe antidepressant medicines, although interestingly, most of the trials that have been done are not convincing that antidepressant medicines work particularly well in those with Alzheimer's disease. The studies have been complicated and not ideal. And because of that, many times people are prescribing antidepressants such as sertraline or citalopram for depression and anxiety and Alzheimer's disease and get some benefit, although the evidence supporting that is somewhat mixed. That we're also more thinking these days, partly because the some folks may not respond particularly well to an antidepressant medicine, to think of other approaches. And using psychological or behavioral interventions appear to have pretty good benefit for depression and anxiety. So we're thinking about implementing strategies such as improving social engagement, cognitive stimulation, exercise, and meta-analyses of these strategies show that there is some benefit. And sometimes when they compare them with the benefit seen with medications like antidepressants, that the benefit may be even greater with these non-pharmacologic interventions. So a little bit messy literature, but I guess the goal here and main point is that we consider medications, but we also consider non-medication approaches, and there's evidence supporting benefit of both. So we think broadly in our management strategies. Another symptom in Alzheimer's disease is actually very common and I believe often overlooked, is that of apathy. Apathy is not depression. There's not particular sadness, hopeless, helplessness feelings, but just disinterest and emotional disengagement and just attending to fewer things and being less engaged with the world. And that, you could ask yourself, gee, why is that a problem? But what we've learned is that it's tremendously distressing to people and their families just to have people just disengaged from the rest of the world around them. And that then exacerbates their lack of stimulation and lack of cognitive input that has an impact on their Alzheimer's disease process. So we're aware that it's an important contribution to the disability of Alzheimer's disease. And there's a neurobiological framework behind it that we can talk more about. And you can see in that upper right panel, it's lumping some studies from a couple different results from a couple different studies, but the prevalence of apathy in older adults, those with mild cognitive impairment, and those with dementia, Alzheimer's disease dementia over time, going to the right, the prevalence gets quite high, up to about 50% of people with Alzheimer's disease have notable apathy. So it's something we're always thinking about and encouraging family to be thinking about, partly because this may be less work done here with management strategies, but just encouraging people to be engaged because their apathy is a problem. They tend not to be easily engaged, but to gently encourage folks to participate more in the world around them, stimulating activities, daycare programs, and that can help just kind of keep them engaged with the world around them. And then consider medications are somewhat controversial. There's been some work suggesting that methylphenidate, which is a stimulant up to a modest dose, can actually be helpful for apathy and Alzheimer's disease. So sometimes clinicians are prescribing this. And then in the remaining few minutes, I wanted to mention this relationship between psychiatric symptoms, early in life and in the earlier stages of Alzheimer's disease clinically, and the progression of Alzheimer's disease. As I mentioned before, that those who have late life apathy, irritability, anxiety appear to be at risk for progressing from being cognitively unimpaired to mild cognitive impairment to Alzheimer's disease dementia. So there's something about these psychiatric symptoms late in life that are either leveraging the neuropathology of Alzheimer's disease itself or are early expressions of the Alzheimer's disease process. And so that's still being worked out, but I think it's this constellation of symptoms now has got a name called mild behavioral impairment to contrast it with mild cognitive impairment. They can both overlap, but highlight the presence of cognitive symptoms like memory, recall, visual perceptive skills, executive skills, language abilities versus behaviors such as delusions, agitation, anxiety. Usually earlier on, it's anxiety, apathy, and irritability that are these symptoms we're looking for. And there's some interesting relationships showing that these symptoms are likely linked to the amyloid pathology of Alzheimer's disease. So it's probably the illness itself talking an early expression of the illness. It also aligns with some interesting observations that depression is, in fact, a risk factor for dementia, and that there's some evidence suggesting that even early in life, people with a major depressive episode in their 20s or 30s are at higher risk on average of developing Alzheimer's disease dementia later in life. That there's still work being done understanding exactly what the critical period is. It may be that late life depression is more distinctly linked to developing Alzheimer's disease. But I think the point here is really two. One is that the neurology and psychiatry of Alzheimer's disease are entwined, and we need to see them as a shared clinical construct. It also means, for me, it adds to the importance of tracking psychiatric symptoms late in life, not just because people have psychiatric symptoms that warrant careful evaluation and treatment, but it may actually be protective of help protect against developing Alzheimer's disease memory difficulties later on. This panel highlights that fact of progression, that on the right, those spaghetti plots and lines show that among people who were cognitively normal at the beginning of the study and had a total behavior score of 0, 1 to 4, or greater than or equal to 5. So none, small, or medium levels of psychiatric symptoms, cognitively normal, and then tracked over time, that their memory scores, you can see those who have the higher psychiatric symptom scores on the far right, their slope of decline, their decline in memory over the subsequent 10 years is significantly greater than those who have no psychiatric symptoms. Again, highlighting the impact of psychiatric symptoms on cognitive progression among older adults who don't have memory impairment at the beginning of the study. And then finally, one might ask, why might this be and what can we do about it? Why it might be remains unclear. That some work on the left-hand side there shows that people of any age with a major depressive episode or disorder have, based on imaging evaluation of brain inflammation, those who have depression have a depressive disorder, so they have recurrent episodes of depressive symptoms, have more inflammation in their brain based on PET imaging. And inflammation, we know, is not great for the brain. It has an important role to play in some settings, but chronic inflammation is not great. The other thing that was noted in the study was that those who, the biggest link was with years of untreated major depression. So that inflammation in your brain may be linked to the number of years one's experiences a mood disorder that isn't being treated, suggesting that treatment of major depression can have an impact on brain inflammation. Similarly, on the right-hand side, tracking people who have mild cognitive impairment, and then looking back to understand, did they have depression over the course of their life, and was it treated? those who had depression but had had substantial, appropriately enduring treatment for their depression with an SSRI antidepressant medicine, their progression from mild cognitive impairment to Alzheimer's disease was less rapid than those who were not treated. Again, the point here is that depression is a risk factor for progression on the cognitive progression. On the other hand, there's some preliminary evidence that that may be treatable, in this case with antidepressants, but in other ways that we may learn about in the future. So I think I'll wrap up there, just highlight some of this, again, interesting interplay between the neurology and the cognition of memory, but also psychiatric symptoms. So in closing, I'll also mention a few resources that you may find helpful listed here. The Alzheimer's Association is always the go-to source for good information. The Caregiver Center that's online has some monographs on neuropsychiatric symptoms and how to approach them. A book by Peter Rabins and colleagues at Hopkins called Practical Dementia Care. It's now fairly old, but it has an appendix that's available. You can download it for free online. That talks about some problem-oriented and brief approaches to managing psychiatric symptoms in Alzheimer's disease. And finally, the Family Caregiver Alliance, which is a group that fosters advocates for people and families, people with Alzheimer's disease and families, has a caregiver's guide to understanding dementia behavior. So you might consider that as well, just to provide a little bit broader range of ideas about how to approach these, how to understand these symptoms and approach their management. So I think that's it for me. I hope you find that helpful. We've got some time for questions, and I'd be happy to take them. And I think Kim will be moderating, yes?
Absolutely, Dr. Sulzer. So yes, audience, go ahead, and if you have questions for our presenter, you can type them into the chat box at this time. And while you're doing that, I'll just go over a couple of little housekeeping things. One is, as always, we want to remind everyone of the importance of being aware of implicit biases or unconscious stereotypes as we care for others. A best practice is a person-centered approach where we view each person that we care for as an individual with unique needs and preferences. And of course, we treat them with dignity and respect, even when they're very different from ourselves. If we always listen carefully and respectfully so that we can understand their perspectives, values, and preferences, then of course we can build trust and provide the highest quality of care. I also want to take a moment just to thank our sponsors once again for making this presentation and all of our webinars possible. And so thank you, O'Connor Mortuary and Caring Companions at Home, as well as our own Alzheimer's Orange County. We do have a couple of webinars coming up next month that I want to tell you about. One is rights-based dementia care on September 25th at 11 a.m. And the other is our next webinar, our next monthly webinar, which is communicating through the stages of dementia. That's Tuesday, October 8th. And you can find information about these and other educational opportunities on our website, www.alzoc.org. Okay, so let me take a look at our questions. Oh my gosh, we just got populated with a bunch of them. So let's see. Are there many differences in people who develop Lewy body dementia from those who develop Alzheimer's? And I guess they mean from a behavioral standpoint.
Yeah, the way that Lewy body dementia and Alzheimer's dementia appears clinically is a little bit different. They have different symptoms. Focusing, as Kim suggests, on neuropsychiatric symptoms, the pattern, the profile of psychiatric symptoms in each dementia is a little bit different. And in this case, Lewy body dementia, as I mentioned, is things like visual hallucinations are actually part of the diagnostic criteria for Lewy body dementia. And other things that occur in Lewy body dementia, there can also be some apathy, although that occurs in Alzheimer's disease as well. Delusional thoughts may occur in some Lewy body dementia people early on. Again, we're talking about compared to perhaps later on in those with Alzheimer's disease. So those are some of the few distinguishing features. Anxiety and depression, the jury's out on that. There may be a little more depression in those with Lewy body dementia, again, particularly early on in the course of illness compared to Alzheimer's disease, but that's not entirely clear. So to Kim's point, I mean, we see each person individually and work with the symptoms and signs that they present so that we're providing the best patient-centered care that we can.
Yes, I was just thinking about Lewy body too. What about the REM sleep disorder? Is there anything in particular that works most effectively for that you're aware of, Dr. Sulzer?
No, there's some medications that are used to treat REM sleep disorder. In my clinical experience, it's a good example of something that's kind of tricky. And because folks may be sensitive to side effects of drugs and the magnitude of benefit, in my experience, varies quite a bit. So we consider medication trials. A lot of it depends on the severity of the actual motor. What we're really treating as part of the REM sleep behavior disturbance is the restless legs, because that's what's most distressing. People with REM sleep disorder aren't always aware of it. It's their sleeping partner who's aware of it. And so we're kind of focusing on the magnitude of leg movements and making decisions about whether to treat. Does that help, Kim?
Absolutely. Thank you. Um, would lecanemab, I always mispronounce that, lecanemab or donanemab be effective for types of dementia other than Alzheimer's disease? And please forgive my mispronunciations.
That's fine. They're not easy. A group of people decides what to name medicines, and I think they entertain themselves by making them difficult to pronounce. That we don't know whether lecanemab or donanemab works for other kinds of dementias. One would predict, remember, those two medicines are anti-amyloid antibodies, so they're given by IV infusion, and they work by removing the abnormal amyloid protein from the brain. Many other dementias do not have amyloid in their brain, so one would predict that they wouldn't be effective for things like, well, I mentioned Lewy body dementia. On the other hand, another great truth is that these dementia syndromes can overlap when their brain comes to autopsy, for example. They have a mix of pathologies. So the short answer is we don't know whether these medicines would work, but it's important, it's important not to treat non-Alzheimer's dementias with these medicines because they have side effects and risks, and the likelihood of benefit is really not knowable. And that people, to be a candidate for lecanemab or donanemab treatment, you have to have a PET imaging study of your brain demonstrating amyloid in the brain. So folks might not be included on the basis of that exclusionary criteria. But we really don't know in the long run. There are other monoclonal antibodies being developed for other kinds of dementias. They're much earlier on in development. So we'll learn more over time. But at this point, those two drugs that are FDA approved are for mild cognitive impairment and mild Alzheimer's disease dementia only.
Thank you, Dr. Sulzer. Let's see, it starts with a compliment. Great presentation. Many thanks for that. I have a question related to the effect of positive visual and auditory stimulus on reducing neuropsych symptoms.
Yeah, it's a good question. And I think that from what we know from research studies and that of clinical experience, myself and others, that the goal with the visual and auditory stimulation is to kind of hit the sweet spot of some stimulation, but not overstimulation. And it depends on the setting that you're talking about. But for example, in care homes or skilled nursing facilities, because of the architecture of the building and the acoustics in the hallways, the sound level, and the fact that people are watching TV and their hearing isn't very good, and the volume is turned way up, that sort of overstimulation can be distressing and promote things like agitated behavior. On the other hand, too little stimulation has also been shown, and in my experience, contributes to other psychiatric symptoms such as depression, anxiety. People do better when they have the right level of visual, auditory, and motor stimulation. Things like taking a walk or getting out and getting some exposure to things beyond what they're used to, just some novel input can be helpful up to a point. And you have to just kind of see for an individual how they do with more or less. Each one of these trials, all the management strategies I've mentioned are really an exploration for each person. What I've described are general principles and the way we think about things, but you just have to kind of try and see what works. And what may work really well for one person may not work so well for another. So it's an exploration, recognizing you'll get to a point. I think I want to be optimistic that most people with agitated behaviors will experience notable relief with some thoughtful interventions over time.
Thank you. Has there been any comparison between depression treated with therapy and depression treated with meds? Is the finding you just mentioned about depressive episodes receiving medication indicative that meds should be used more often and in less severe cases?
Yeah, that too is a good question and really reflects, it's an example about we only know what we know, and that the studies that have looked at that typically use records going back, looking at people's treatment over time. And and for good or for ill, documentation of pharmacy records tends to be a little bit more available than psychotherapy records. So I would guess that actually it's a good question. I mean, is it the pharmacology of the antidepressant, or is it the extent of depression that's really driving that response? And that, the fact that the extent of depression doesn't always line up with risk for Alzheimer's disease over time. It looks like in a couple of these studies that it's really the medication. So I would guess that it may be more related to a direct pharmacologic effect, but that's just a guess at this point. And it's likely that people treated with psychotherapy who benefit robustly for treatment for depression obviously will have clinical benefit from that treatment over their lifespan, but also may have some benefit with regard to dementia syndromes down the road. But we don't know the answer to that.
But do you feel like therapy is effective for people with Alzheimer's disease?
Yeah, I think for people who have mild cognitive symptoms or mild cognitive impairment, that syndrome, or people
Mm-hmm.
who reach a threshold of having uh, uh, Alzheimer's disease dementia, that therapy can be helpful. That unfortunately, people, as their cognitive symptoms evolve over time, their ability to kind of work within the therapy, to remember things. I
Yeah,
mean, cognitive behavioral therapy, we know is a great treatment for depression. That's hard to do when folks just can't do the work, basically,
right.
unfortunately.
Right.
On the other hand, the support is beneficial. The engagement with others is beneficial. The attention that others pay to their internal state and well-being is important. So I think it has a role to play. It's just only up to a certain point in Alzheimer's dementia.
Okay. And speaking of engagement, someone is asking, how do you encourage social engagement when the senior is afraid of getting sick? For example, citing COVID as a reason not to go out or do things.
Yeah, a good one. I mean, I think it's important to understand, is their concern about COVID, is that coming from, how much of that is coming from their cognitive disorder? If you're talking about somebody who's Alzheimer's dementia, is it kind of an unrealistic concern? And we don't know what realistic concern about COVID is, frankly. We all vary in our concern level of concern about it. But I think, just to try and be reassuring that folks should be vaccinated. This population is a group that should benefit from vaccination. And then to just kind of work with them and respect their belief. So it's just kind of finding that balance between, what they're comfortable with. Is their concern, quote, reasonable, recognizing that there's no perfect benchmark for reasonable. But I'm kind of thinking about somebody who may have heard about COVID, who has dementia and is excessively concerned about that, i.e., if they're going outside with somebody who they're with indoors all the time and there's nobody else around, their risk doesn't go up. Now, you can't convince somebody with advanced dementia of that if that's what they believe. And
Right.
what you don't want to do is argue with people. On the other
Right.
hand, that's kind of unrealistic. You just try and maybe more reassuring or distracting, or remind them that I don't want to overstate the value of vaccination, but in this case, to let people know that you're vaccinated, you're fine. And I'm being a bit facetious, but in the service of calming somebody's concerns.
And I think too that sometimes people just feel more comfortable at home in their own turf, and they will use an excuse to not go outside because of that. And so, to find things you can do inside is okay, right?
Yeah, absolutely. That's an excellent point, Kim. And it gets back to that overstimulation versus understimulation issue for sure.
Yeah, it's tricky. Someone is asking if Seroquel plays a significant role in treatment of psychiatric behaviors and dementia. I think you covered that, but maybe you could summarize that.
Yeah, it's worth pointing out because among the atypical antipsychotics that are prescribed for agitation or psychosis in Alzheimer's disease and other dementias, Seroquel is probably one of the most frequently prescribed at 25 or 50 milligrams. Just for your information, there's never been a study of Seroquel at those doses that show any benefit on average. So the most commonly prescribed and dose of medicine is not only has it not been shown to be effective, it's been shown in studies to be ineffective. I think that reflects the challenge in the field with these things. And it really reflects local pharmacotherapy culture, is the way I refer to it. People are comfortable with it. Atypical antipsychotic trials show that about 40% of people treated with placebo get better. So that it's possible that the Seroquel per se may not be driving the perceived benefit. That said, there's probably some people who respond quite well. I'm not opposed to Seroquel. It's just if you're following evidence-based medicine, that would not be your first choice. And the doses that have been shown to be effective of Seroquel are much, much higher than 25 or 50 milligrams. Still a good idea to start low and go slow with psychotropic meds in this population, but go and try and get to a dose that may be beneficial.
Thank you. Do people using medical marijuana have more manageable psychiatric symptoms in dementia?
Yeah, that too is a great question in an area of active research right now. The one of the consortia that we work with here at UC Irvine um, is doing a trial. We're not involved at a site of a combination of THC and cannabidiol. Cannabinoids are a whole group of different compounds, and when we're talking about the effect of cannabinoids, which is the broader group, it's important to sort out, what actual um, chemical is in the compound that's being treated. But there's some evidence that it's beneficial. It's not really been shown in traditional scientific studies, but some of those studies are ongoing now, and some people find benefit, particularly from cannabidiol. My concern for THC, which is the more robustly psychoactive compound that's found in marijuana, traditional marijuana, along with other cannabinoids, it can potentially cause distress in people who are already confused about the world around them. That's not to say it happens all the time, but I think I would urge caution and low doses for starters. But that's something we'll be learning more about, and is a promising area of development going forward, particularly for CBD or cannabidiol.
Great. Thank you so much, Dr. Sulzer. And with that, I think we need to let you go. This has been so wonderful. We appreciate you sharing all the latest research findings with us and your expertise on this subject, which is of great concern to so many of our constituents. So thank you, thank you, thank you. And everyone, please watch for the survey that will open up immediately as you exit the webinar. And don't forget to visit our website, www.alzoc.org, to learn more about upcoming webinars and educational opportunities. And with that, I will say thank you and have a good day.